The Next Breast Thing podcast is primarily funded by the American Society of Breast Surgeons. The support of sponsorships helps us offset some production costs. ASBRS does not endorse or co-promote any company, product, or service mentioned.
This episode of The Next Breast Thing is made possible in part through the generous support of Solventum Prevena Therapy and Mammatome Breast Cancer Diagnostics and Surgical Solutions.
Solventum Prevena Therapy has demonstrated a significant reduction in surgical site complications, infections, and readmissions. Take a proactive risk management approach. With Prevena Therapy, learn more at Prevena.com. That's Prevena.com.
At Mammatome, we offer a comprehensive range of products that deliver better outcomes in breast care. From biopsy to surgery, our advanced technologies empower clinicians with precise, trusted solutions. Together, we will transform the future of breast care. Learn more at Mammatome.com.
Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast wherever you listen to podcasts.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
On this episode of The Next Breast Thing,
I can't say it enough how much doing these two things that are totally different from surgery has added to my life over the
I will tell you, the first time I did it, the headache that I developed and the mind fog from the lack of...
How do we get this colorectal PA up to speed with breast surgery?
Backed by popular demand, let's talk about some of those things that we didn't cover in our last DCIS podcast.
so what is shared decision-making?
If we don't have shared decision making, should we just decide for them?
The use of sentinel lymph nodes for DCIS.
Okay, I'm going to dust off the old devil's advocate here. If you're going to do a mastectomy for DCIS, if you decide that nobody wants to go back to the operating
What
room,
percentage of the time do you have to go back?
seriously, we're not doing a dissection. You're
And
clicking the nail
wait,
right
look at
there at the
me.
tail of fence.
I thought this would be our lob discussion.
The devil had to come up.
This is Carla.
Ellie,
Michael.
Susie.
And Susan, welcome to The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community,
We're a group of devoted surgeons from different parts of the country.
inviting you to journey with us into the science of breast.
Through the heart and soul of our breast community.
From advances in procedures and patient care to personal transformation, we're here to support you.
so if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.
Our topic today, almost backed by popular demand, is to finish a conversation that we got started on ductal carcinoma in situ DCIS. This time we're going to take a little bit of a hitch and we're going to go beyond surgery. But before we get started, let's begin with some personal and professional updates. Susie, what life-threatening thing have you been involved in recently?
Nothing life-threatening. I worked at the farm today. I mixed about 1,000 pounds of grain. And then last night, we had our 1-year anniversary for our Mahjong group. And I can't say it enough how much doing these two things that are totally different from surgery has added to my life over the past year. So I encourage someone to go out and find anything that's different than medicine to enrich your life.
Oh, that's lovely.
Carla, tell me about you.
I am doing a little bit for myself in the new year, doing a little bit of a detox. So I like to do these twice a year. I basically go a week without caffeine, sugar, preservatives, you name it. It's crazy what your body goes through. I will tell you, the first time I did it, the headache that I developed and the mind fog from the lack of caffeine was tremendous. I will tell you, the headache is kind of hitting me right now, but the lack of caffeine has not been too bad. So I figure it's probably good to kind of just flush things out of my system twice a year. And I didn't do it last year just because of everything that was going on. So, Ellie? It sounds like something you might do. So transitioning to you, what are you doing these days?
I'm just laughing because going back to work Monday after the New Year's and the holiday, my staff was really dragging. And I was like, what is wrong with you guys? Why are you so tired? They couldn't put in orders. They weren't doing anything. And I was like, what's wrong? And they're all like, oh, we're all on diets. We're all off caffeine. We're all off sugar, just like you're talking about. And they were all on withdrawal of all that stuff, actually. So it was pretty funny. Now, obviously, coming off the holidays, it's a little not exciting, but they were really not effective. I kind of do that throughout the year, so it's not as abrupt after the holidays. But no, it's new with me. I actually did finally negotiate my way to a PA of my own. So she's starting soon. I'm going to put her through the APP course with ASBRS. So thank you guys again for creating that, because again, we were like, how do we get this colorectal PA up to speed with breast surgery? And the ASBRS APP course was just perfect. So we're going to sign her up for that. And yeah, I'm just really excited to have full-time help. So that's my update. And yeah, it's going good. Susan, how about you?
There's so much going on. But I can tell you, hiring a new PA, especially someone who was specialized in colorectal and bringing them into breast, is so much added work, and it will come back to you in droves. So my advice is invest all the time that you have into teaching and training them and being patient, and that everything you would want in someone teaching you, give to them, and you will be so rewarded back. It really is incredible. It is life altering. And once you work with a great APP, you will wonder how you could ever have lived without one in the office setting. It just makes work more fun. You really have a partner in all of this. So it really is great. So Susie, I'm not quite at celebrating a year with Mahjong, but approaching it. And I have a group of friends that we have known now each other for over 15 years. So we have gotten together and play once a week now. I haven't decided yet if I really love it. I think I do, but we go back and forth. We're like, do we love this? Are we loving this? So for Christmas, everyone got their own sets, and the text group back and forth was everyone showing off their new set. We rotate to everyone's home. Yeah, it's awesome. And we know each other for so long, and everyone knows their kid. It's just great. It's a great fellowship or community. So, Michael?
Isn't Mahjong like a GLP-1? Isn't that a fat shot? Is that what that is?
We eat our way through the game, so I'm not sure that it is for us. Starts out with dinner, and then we go into the game with snacks.
I'll have you know that I finished season 9, episode 4 of Dr. Manahan. Tell us a little bit about yourself. And he went to Auburn, evidently. I made it through, though. They say, you could skip season 2, and I would say skip season 2, get to season 3, and then it picks back up. If you haven't listened to that podcast, it's a genetics podcast. It's only about 37 hours, and I think it is great. We're going to see if we can get it on Netflix.
We're doing a great job at self-promotion here.
But it gives you the history of how we came about our guidelines on genetic testing. And it really was an incredible process, and I was privileged to be part of it, but I forgot how much work. We had people nationally, we had medical oncologists, we had so many people involved in this process. So just taking you through that is worth the listen.
It really was cool. And it sort of kind of shows you how the sausage is made. And it's a lot different than what you think, that people just sort of sit around a room and everybody agrees and you just put something on paper. There's a lot that goes into that. Let's move on to our topic, and it is DCIS again, but we're going to deviate a little bit from where we covered previously on our podcast, and we're going to talk a little bit beyond surgery. We're going to talk about genomic testing. We're going to talk about radiation. We may hit on endocrine therapy. Let's talk about some of those things that we didn't cover in our last DCIS podcast, and let's go ahead and get started. Who wants to hurl the first shot?
I'll get started. And I do want to talk about surgery that we didn't finish or touch on the last time we talked about this topic, really just for completion's sakes. We had a lot of discussion about whether it was cancer or not. Everybody ganged up on me, but I'm okay from that. We talked a lot about shared decision making. Interestingly, I've listened to a couple other podcasts talking about DCIS and read a couple, as we all have, different articles. And, shared decision making comes into our field quite a bit, but especially in DCIS.
Let's talk about shared decision making. I will give you an example. I brought my daughter's car to the mechanic, and he listed 5 things that needed to be fixed. And it was shared decision making. I know nothing. I know how to put gas in my car, how to fill the tires up with air, and that's about it as far as how to take care of the car. So sure, we had shared decision making. And my question was to everything, how much is that? How much is that? Do I really need to do that? I had no clue what he's talking about. But at the end of the day, it was shared decision making. And he would say, well, you agreed to everything. But did I really? Do I understand it? So what is shared decision making? And are we fooling ourselves thinking that we really have it in everything we talk about with a patient? Susie, I know with every ounce of your being, believe that you have shared decision making. But when there is such a difference in education and understanding of this specific topic, this mechanic spent 40 minutes talking to me about all the things. And I walked away and I didn't understand a single thing that he said. And he was so patient and he drew pictures out for me. I understood nothing and agreed to everything. I mean, I have to get a second job to pay for this car that doesn't have that much book value to it, but she needs the car. So it did make me think about when I walked away, I was like, oh my God, is this what all of our patients feel like? And we feel like, yes, we have shared decision making.
Yeah, but he also took 40 minutes to talk to you. And so he gained your trust, right?
That's totally different. Patients have to trust us or they're not going to let us operate on them. So if we're operating on them, they trust us. But is it informed, shared, educated decision making?
I think so, because it's informed consent in a way.
A lawyer will tell you there's no such thing as informed consent. A defense lawyer will tell you informed consent all day long. But is there really?
So I re-listened to that podcast, and I think our intent is important. And I think it is okay to present more than one side. And in my personal practice, if a patient asks me, what would you do? I'm honest with my situation, but my situation is not the same as theirs.
That's interesting, because when a patient asks me what I personally would do, I give them the most honest answer that I can. I don't know. Until I'm sitting in your chair, I don't know what I would do. If you asked me that question 20 years ago, I might give one answer. 20 years from now, I might give a different answer. So I cannot answer that question honestly until I'm sitting in that chair at that point in my life.
That's fair, for sure, within that moment. And it's okay that we change our minds, and it's okay that we have new research that may shape that.
I'm curious at what you're getting at, Susan, because what would be the converse of this? If we don't have shared decision making, should we just decide for them?
No, I think we talk so much about shared decision making. I spend a ridiculous amount of time with my patients, and I go through every possible option. Every patient gets the discussion of partial mastectomy or a lumpectomy, same thing compared to a mastectomy. If I think they need a mastectomy, I still go through lumpectomy and I tell them why I don't think they're a candidate. If I think they're a candidate, I say mastectomy is an option, but I think you're a great candidate for a partial or breast conservation and that there's no survival advantage to the other. And I go through all of that. My point is we hang our hat and we scream it loud from the mountaintops. We believe in shared decision making. Oh, yes, I believe in it. And Susie, when we have these discussions that we go back and forth, you're like, well, I talk to the patients. We all talk to the patients. We all do this. My question is it really, when it comes down to it, shared decision making because we all have our biases and we present information with bias. That's my point. I believe we have to spend as much time as that patient needs. We have to educate them. I think more than half of our jobs is educating patients.
I think there's a whole field of people that study shared decision making, and it's definitely something that is evolving. I also think that we are in a data saturated field where people seek out data, and sometimes we give patients data and they make decisions based on that. And we all feel good about that information. And then we sometimes have these interactions where data leads to no better decision. We're just seeking data and seeking information, and people sometimes are just seeking that information and don't know where to go with that. And so there's this sort of, I'm going to use this information to make decisions. And then there's the psychological component of things as well. As a breast surgeon, you can tell when you're explaining facts and sort of going over things and people are navigating that. And when the psychological component is sort of overriding that 4 to 6% risk of recurrence at 5 to 10 years or 2% risk at 10 years, those numbers are like, you literally could just be saying nothing. So I think it's tough, but just to go back to the initial thing, I think Ellie talked about this in terms of shared decision making, but I just wanted to kind of make sure for completeness sake, we talked about it. The use of sentinel lymph nodes for DCIS. And I think in my training, we did talk about doing sentinel lymph nodes for palpable DCIS or high-grade DCIS or sometimes cometonecrosis or ER negative DCIS. And I think occasionally I'll see people, I'm just sort of being very broad, sort of talk about doing that for patients getting partial mastectomies. Those days are over and we really should not be doing that. We know that we have tracers that can stay in patients for long periods of time. And if you have access to that, you can do mastectomies and go back and do sentinel lymph nodes. And I think that's a great shared decision-making discussion. But especially as we de-escalate sentinel lymph nodes in patients with invasive cancer, I just think for our listeners, don't be doing sentinel lymph nodes that often in patients with DCIS. And if you're doing a mastectomy in a patient with 5 millimeters of DCIS, I don't think you need to do a sentinel lymph node most of the time.
Well, why are you doing a mastectomy? That's question one, right?
Well, a lot of times that's because the patient wants it. If you haven't been in that situation, good for you as a surgeon, but I've been in that situation lots of times.
Okay, I'm going to dust off the old devil's advocate here. If you're going to do a mastectomy for DCIS, if you decide that patient has enough disease to get a mastectomy, you're right there. You're not having to bring them back to the operating room. You're not going to be doing a big dissection. You're not going to freeze that node. How much morbidity are you really adding by just snagging that sentinel node while you're doing the mastectomy? I'm not advocating for sentinel lymph nodes on all DCIS, but it sounds like we've got a technology looking for a surgery, and you're right there.
So think about it. When I'm doing a nipple-sparing mastectomy through an inframammary fold incision, I am not right there in the axilla. So if I'm doing a simple mastectomy, yeah, I'm staring at the axilla. But when I'm doing a 11 centimeter incision and I'm doing these pretty large nipple-sparing mastectomies and pretty large breasts, the axilla is not easy for me to access. So it is an extra incision for me.
I will be praying that when you play devil's advocate, you're actually just trying to be controversial and you don't really think this way.
I think if you're setting out to check a lymph node, nobody wants to go back to the operating room.
What percentage of the time do you have to go back?
Then why do it at all?
Exactly. Why do it at all? With strong imaging, what percentage of the time and pathology in your breast center, what percentage of the time that you're operating on DCIS will you find invasive cancer?
No, we're talking low single digits. It all depends on how big the area is and how high grade it is and was it palpable. I mean, there are things that can move you toward that. But this is a 1 to 2% thing, so why even do it at all? I mean, we can do a sentinel node by injecting technetium into the skin. Why bring a patient back to the operating room to remove a node when you could just do it right there if you think that it's necessary?
Increased morbidity.
Seriously, we're not doing a dissection. You're
Increased
plucking a
morbidity.
node right there at the tail of stents.
Look at B32.
I thought this would be our lob discussion.
that Evel had to come up?
It's a great use for SPIO injection.
I think it's a great thing to offer our patients. I saw a patient very recently who's going to undergo a bilateral mastectomy for a large area of calcifications in DCIS. She asked about risk of lymphedema. I told her risk would be low with a sentinel lymph node biopsy. But guess what? She's actually not going to have any lymph nodes removed because I will be injecting SPIO. And she probably won't need any lymph nodes, and she probably wouldn't have lymphedema regardless. But I get to tell her risk of lymphedema is 0.
So you inject all of these patients that you're going to do a mastectomy for DCIS with this?
Yeah. But to be honest, sometimes if it's 5 millimeters of DCIS, I don't even inject the SPIO.
I don't even like sampling nodes, period. I think you can get a lot more from the genomics. Let's just pivot to that. Let's talk about genomics with DCIS. Are we seeing the same fight for the genomics in DCIS for radiation that we saw with the genomics for invasive disease? Because there's a lot of pushback from our radiation oncology colleagues saying, well, I don't really believe this, or this isn't the best data, or I use it to either ramp up or ramp down the radiation but never turn it off. What's your experience been with genomics for DCIS?
Is anyone using it?
I order it for almost every DCIS patient that fits the criteria. So the certain company, their criteria, I believe, is less than 5 centimeters of disease.
And your rad-oncs?
I order it, and the rad-oncs explain it to them.
At our institution, our rad-oncs use it, and they order it, and they can order it in a timely fashion that does not delay care.
For those that aren't familiar, I was just looking back. So there was the PREDICT study, and that was published in 2024. And I think that was kind of an interesting study. And they basically looked at what people thought, surgeons and radiation oncologists, what they thought based on clinical variables about whether I would recommend radiation or not. And then they used the test and kind of said, based on the information, based on the test, would you still recommend radiation or not? And so the radiation recommendation changed in 38% of women, resulting in a 20% decrease in the overall recommendation of radiation. Of the women initially recommended no radiation, 31% were recommended radiation post-test. The recommendation for radiation post-test increased with increasing score. I think it's just interesting to kind of quote that to talk about what we currently do and how that score kind of changed things.
Carla, that study was not 100 women or so. I think that study had a large number of women.
2,500 enrolled from 2018 to 2022. So obviously a pretty modern cohort at 63 academic and community practices.
Going back to Michael's question, and remember the early days of genomic assays for invasive breast cancer. It took a little bit of adoption, and it worked best when the surgeon and the med-onc worked together. But it feels like this is taking longer to catch on and for people to adopt. Is that a fair assessment? And then why?
I can remember when I was in fellowship, the medical oncologist sort of showing me, saying, this is how I used to decide on a patient needing chemotherapy, and I remember being like, oh my gosh, now you've got this test.
I started using it in about 2007, 2008.
I missed that transition.
Right.
I don't have anything to compare it to.
It is complicated, and you do need a specialized group of people who are willing to continually look at the literature and pull people together.
But what if you've got a group of intelligent, well-informed people that just refuse to accept the data? That's what we seem to run into a little bit, is that, hey, I know better. I know what a high-risk DCIS is, and that is what this is. And all of my prior studies show that this is high-risk recurrence. And then you come back and say, well, this shows that there's not a higher risk of recurrence in the absence of radiation. What do you do when you're dealing with a whole nother field that just refuses to accept? I mean, that's what we encounter with medical oncology. At the end of the day, we don't give the chemo. At the end of the day, we don't give the radiation.
And I think that one of the ways that change was really happened back then was the surgeons started ordering it, or the surgeons teamed up with their med-oncs and said, you know what, we'll order this. It's hard not to follow when it's in front of you. And it's the same thing with this. How do we as surgeons, push the envelope, because right now, one of the main things that they use for determination of radiation with DCIS, besides age, is the grade, which we know is all over the place, and the size. So we are under-treating a certain percentage of women. They say, oh, you're a little older. Oh, it's low grade. It's fine. Well, maybe it's not low grade. Maybe if we gave it to 10 pathologists, it's really not low grade in everyone's eyes. And maybe that if we got a genomic assay, that would come back as high risk and they would benefit from radiation.
Let's talk just a second about endocrine therapy, because we said we were going to do it, and I think we should. Is it always tamoxifen? Is it an AI? Does anybody use ovarian suppression? Give us a clue as to how you are treating these ER positive, PR positive DCISs after whatever surgery you do.
Go to the resource guide on endocrine therapy. If you are not familiar with the basic medications, the basic side effects, they've done a really good job so that you can start that conversation, whether or not you're comfortable prescribing or not, to give you the background on it. And it also includes a lot of studies, but in paragraph format, not like 100 pages.
All right, we'll reference that. Ellie, tell us what you're doing on that.
My standard practice is I introduce the discussion with the patients before we're talking about surgery. I say, this is what to expect after. If it's truly DCIS, there's no role for chemotherapy. Endocrine therapy will be a lot of your insurance policy to lower your risk of recurrence. I also prime them for the genomic radiation test too. And I think that also has kind of helped our radiation oncologists get on board, like you guys discussed earlier. When they have that test in hand and the patient knows what it means, it's really hard for them to explain that, oh yeah, I just don't believe this piece of paper. So it pushes them in a way to be up to date with that.
Sorry to interrupt, but is it recurrence or is it risk reduction?
I mean, I've always said recurrence, but maybe that's the wrong word. I don't know.
I usually talk to patients more about endocrine therapy in the sense of risk reduction in this situation. I think that's what it's used more for, radiation, a little bit more of that local recurrence.
But we go back to our first episode of DCIS, and you don't think it's cancer. The way you think about it and explain goes back to what your beliefs in DCIS are. So that makes perfect sense in your framework. But in Ellie's framework, where in her mind it is cancer, decreasing the risk of recurrence also makes perfect sense in her framework.
The messages we give to patients, as I said before, I think can be confusing in that way. And I will tell you, our patients with DCIS are seen by medical oncologists, but they are seen in our high-risk clinic. So I think that's messaging as well. They don't see our medical oncologists like our invasive cancers. They're seen in high-risk clinics. So I think that tells you how that messaging is also echoed by our medical oncologist. I will tell you that is one of my pet peeves. I think there's a survival difference when you take endocrine therapy for invasive breast cancer. There is not a survival difference when you take endocrine therapy for DCIS.
This is where I go back with shared decision-making. I know you guys are going to kill me, but you're introducing your bias of, I don't believe that DCIS is breast cancer. That is your bias. I don't know if it's right or wrong, but there's 5 of us and 4 of us think differently about it. Again, that doesn't mean it's right or wrong, but our approach to patients is different because of where we start and what we think. Your approach is differently, and apparently your whole institution has that thought pattern. In my institution, my DCIS patients see the same medical oncologist that my invasive patients see, because in our world, it's breast cancer. It's in situ, but it's breast cancer.
I don't think it's a bias or an opinion talking about survival when taking endocrine therapy for DCIS versus risk reduction versus recurrence. There is a benefit, lower recurrence, but no benefit to overall survival.
Michael, I do have a question. I know you are all shocked that I have a question. We touched on genomic assays for DCIS. What is MolDX and what's happening with them?
Basically, CMS will assign to different areas that cover multiple states decision-making on whether or not something is covered. And you think about it as regional. Oh, well, this is just a couple of states. But the decisions that are made, and MolDX, I think, stands for molecular diagnostics. And they had recently made a decision that the ASBS sent a letter kind of saying, hey, we don't agree with this, that genomic assays for DCIS are not going to be covered. They have been, but they just sort of changed their mind. And even though there's pretty good data, and the data is better now than it was when it was originally approved. So we need to be aware that these things are out there, and that if they're coming for genomics on DCIS, what's the next step? Do they come for genomics on invasive cancer as well? So you can't let them get the foot in the door. Yeah, it would save CMS a lot of money. At the end of the day, it's removing a piece from the patient that may be important for them just as a cost saving. And it's always hid behind, well, there's insufficient data or it's experimental or whatever else. But that is a decision that affected 23 states, and you could see that ripple across the United States. So that was a big decision that we're going to see what happens. I don't know that they've reversed that decision yet.
What can we do as individual surgeons or as advocates about this?
Well, the society wrote a letter. That's something that you can do. If you live within these Eastern Seaboard states, you can write individual letters and tell them how it's affecting your patients and how you're removing a decision point for these patients that may actually save money if it says that they don't need radiation therapy, and really kind of lean on folks. Even talk to if you've got a relationship with your representative, talk to them, because they may or may not even be aware that this stuff is happening. It happens on an administrative level, and this may not be a decision that Congress makes, but I guarantee that your representative can put some weight behind that and put some heat on some folks.
Do we have information on that on the website of the society so our listeners, our members can go look and then reference it with a letter?
I think you can look for the statement that we made. I'd have to look up again and see if there's some way that individuals can contact. But we did place on the website the letter that we had sent in our opposition to that decision. Before we close, let's go around and have each of you share one thing you'll take away from this episode. Let's go back to you, Susie.
As much as I hate to say it, and I never want to talk about it again, it is important to understand we do come into these visits with some bias. In shared decision-making, we do have so many years of education, and it may be very clear in our head, and allowing the patient as much time as they need to get to a decision that they feel comfortable with as well.
Ellie.
This episode, again, I'm just reminded of how much I learn just hearing the history of the evolution of things. You just figure it's always been this way, and it hasn't. And I just love hearing origin stories of everything. So thank you guys for sharing.
Carla.
Endocrine therapy is tough, and it's something that we are exposed to a lot because our patients are taking it, and we talk to patients a lot about it. But at the end of the day, I am not the one prescribing it. We didn't talk about low-dose tamoxifen, but I think it's something that every patient who is talking to their doctor about endocrine therapy should be asking about. I think it's an incredible story if you hear about why we prescribe 20 milligrams of tamoxifen and why we're doing these studies now looking at less and less tamoxifen. And I think it's really changing the ability of a lot of women to take endocrine therapy, and probably will shift some of these discussions about endocrine therapy. And especially in DCIS and in postmenopausal women, we should definitely be considering low-dose tamoxifen.
Susan, share your decision.
First, I like the term low-dose tamoxifen better than baby tam. I definitely like low-dose tamoxifen better. But as opposed to what I learned, because I always learn so much from all of you, and in between our recordings, I do forget how much I enjoy spending this time with you all.
To our listeners throughout the breast community, we're so excited you've joined us on this journey, and we'll see you next time on the Next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla.
Ellie.
Michael.
Susie.
And Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the next breast thing.